Good morning, everyone. Sabah al-khair. Thank you, Mahideen, for this very gracious introduction. When I was asked to give a keynote, one of the keynote speeches, I wanted to really I was thinking what's the best way and what should I approach it and how should I approach it. And when I thought after some thought and deliberation that I'd kind of share with you how I've seen GYN oncology evolve over the past 20 plus years that I've been involved in it. And in fact, the past 30 years that I've been interested in it. I've always had that interest when I was going through training, and I wanted to kind of go into it. And when I ended in a fellowship, just kind of had cherished it a lot, and then things have changed since. So just to give you a little bit of a background of the history, as you remember, GYN oncology has and continues to be the surgery where the field where we do major radical surgeries. So what GYN oncologists were most known for, and the field was most known for, was the radical surgeries we did, the radical hysterectomies and the exenterations, and the long and complicated surgeries, and patients staying in the hospital a week or 2 weeks. A lot of morbidity, and it was significant relative mortality. It was not unusual to have patients die after surgery. It was not frequent, but it was not unusual, and people accepted it. At no time, people looked at quality of life at that time, and the treatment, in addition to surgery, were rather limited. So when we started giving radiation therapy initially for cervical cancer, I still remember when we did our planning on plain X-ray films for patients who have cervical cancers. With respect to the medical treatment, the chemotherapy was really rather limited. So there was a breakthrough in the 1970s when they discovered cisplatin, and then after that in the 1990s when Taxol was introduced, and everybody felt that we are great. And there were a lot of other drugs, chemotherapy drugs, that were introduced and brought to the list, but their efficacy has not kind of impacted significantly what we were doing. So the first part of my talk, I'm going to kind of discuss a little bit of surgical advances. So over the past 2 decades, the concept of surgery has changed significantly. And it has changed not that we should not do surgery, but surgery does not need to be as morbid and as radical as we thought before. So if we look at endometrial cancer first, we have learned very clearly that we can do most endometrial cancer cases at the present time through a minimally invasive surgery approach. There has been large randomized studies that has been done, and the study has been very, very clear that we can do it with as much efficacy from each outcome, less morbidity, less complications, and better quality of life for patients. And this is a study that looked at the NSQIP, the National Surgical Quality Improvement Program, between 2006 and 2010. And as you see here on the right side of your slide, where you see a significant increase in the number of minimally invasive surgery for endometrial cancer and decrease in the exploratory laparotomy. I can tell you that the majority of our patients at the present time with endometrial cancer, even when they have lymph node dissection, end up going home within the same day or within 23 hours. In fact, most insurance companies in the United States do not allow you to keep a patient longer for an endometrial cancer and minimally invasive surgery. Lymph node sampling and lymph node staging is an important part of what we do with cancers, gynecologic cancers. For example, in vulvar cancer, the old approach was the approach that you see on the right side of the graph, the lower part, where we had in the old days these big en bloc resection where take the vulva, take the groins, again, huge incisions that were hard to close, they break down, patients were in the hospital forever. Well, data is very clear at the present time that you can do sentinel node mapping, similar to what you do in breast cancer, and this can be done in conjunction with both a dye as well as lymphoscintigraphy, and you end up taking one lymph node versus taking multiple lymph nodes, and if the lymph node is negative, it has been really shown that these patients do as well as doing a complete lymph node dissection. The question of lymph node dissection and endometrial cancer has been long debated. I know a couple of years ago we discussed that, we shared the data here, and I know there is still some controversy across parts of the Atlantic, but even within Europe, how much and how aggressive you should be with lymph node dissection. There is more and more of a movement at the present time that accepts lymph node dissection in the sentinel node mapping in the pelvis as an alternative to a complete lymphadenectomy. And in fact, at the present time, the National Cancer Recommendation for lymph node sampling in endometrial cancer has been accepted. So did this less aggressive surgery and more conservative approach impact patients' outcome? As I mentioned, with vulvar cancer, we know extremely well that patients do as well. With endometrial cancer, we have seen the same. In fact, cervical cancer also is another approach where we have started doing sentinel node mapping, and it seems to be as successful. We've had less complications, better short and long-term outcome. If you look on the images on the right-hand side, the one on the bottom, it was not uncommon when we used to do lymph node dissection in the groin, and the patient used to have radiation afterwards, severe lymphedema that was crippling, women were in wheelchairs, versus now it is very unusual to see significant lymphedema when you do sentinel node mapping. This came, however, at a cost, because with a lot of these things there are cost implications, and the cost implications are related to lymphoscintigraphy, knowledge, who's training, who is doing it, how often are they doing it, with a lot of mapping that is done also in the using laparoscopic or robotic surgery. In addition to the dye, other things can be done. And the other issue is access around the world. So although these things can be easily implemented in the Western world, the question is how much they can be implemented in the rest of the world and what impact that will have on cancer's treatment. With ovarian cancer, that move toward radical surgery has not changed. And I know there are a lot of discussions back and forth at the present time. Should you give chemotherapy first? Should you do surgery first? It is very clear for every single publication, and this is as late as last year, this is a common statement from the Society of Gynecologic Oncology as well as the American Society of Clinical Oncology. The same, our European friends have exactly the same recommendation, that surgery continued to be one of the primary and mainstays of ovarian cancer treatment. So every single patient who has ovarian cancer, even if advanced, need to be given the chance of having a radical surgery up front, followed by chemotherapy. At the present time, there are a lot of studies to kind of see whether we can discriminate and differentiate between patients who can undergo optimal debulking up front and those who cannot undergo optimal debulking up front. But again, the goal is to do optimal debulking up front, irrespective of what we have. So this is a place when it really, the data at the present time have confirmed the need to continue to be radical and that the outcomes are impacted by that radicality. An extremely important concept that is gaining a lot of wind at the present time in the United States and in Europe, in fact, because I've seen some of our colleagues in Europe presenting that, is the concept of enhanced recovery after surgery. So I've talked before about, in the old days, it was not unusual really for us for an endometrial cancer patient to come in, we do this big laparotomy, they have NG2, we don't touch the NG2 for 4 or 5 days, the patient has a Foley catheter for a few days, we don't do anything with it, their blood sugar, they are diabetic, blood sugar is going up, down, we are managing them in the hospital. An endometrial cancer case used to take, as I said, 6-7 days in the hospital in the old days. At the present time, not only with robotic surgery, but also with preparing patients for surgery, it became very, very important that we do this coordination of care before surgery, during surgery, and after surgery. In fact, at the present time, this has challenging a lot of the concepts that we had before. So before we used to say, well, every patient who needs to have surgery, bowel resection, we need to kind of keep them MPO, do bowel prep on them, complete bowel prep on them. And the concept of this MPO, nothing to eat before surgery, has changed significantly. There is more and more data now that you should feed the patients up till 3-4 hours before surgery. You need to keep them hydrated the day before surgery. During surgery, in the old days, we used to flood the patients with fluid because we said there are going to be a lot of third spacing. And now the data, you need to be conservative in doing this. And after surgery, the use for non-opiate analgesia has also gained more and more popularity because it was felt that by adding this kind of comprehensive care, pre-op, intra-op, and post-op become very important. The use of things like drains have almost gone out of use in the United States. I can tell you again, going 20 years ago, it was not unusual for us, for every single patient that we operated on a day, to end up with drains, sometimes right, left drains. Now, I can tell you, I cannot remember the last time I left the drain in a patient, irrespective of how aggressive the surgery that we have done. Fertility preservation. 20, 30 years ago, nobody would have thought or guessed that anyone would be discussing fertility preservation in the context of gynecologic cancer. So with cervix cancer, well, how can you talk about fertility preservation? It is a cancer just there in the uterus. You need to take it out. Well, the reality number one is you can. We have proven that even with early stage microinvasive cervical cancer, equalization can be the complete and final treatment and is curative. Number two, that even in patients with early stage disease, you can take the cervix, preserve the uterus, and women can get pregnant after that. And number three, even in patients who lose the uterus, if you preserve their ovaries, they can donate eggs and they can have surrogate people to kind of get pregnant. I know sometimes it is not acceptable in cultures here, but it just gives you an idea where the concept has evolved in that respect. With ovarian cancer, for those who attended the talk yesterday that I have given, an ovarian germ cell tumor, the mandate is that we should be fertility preserving in these patients, that in young patients we should preserve the ovary and be as conservative in approach that we need to have. And even in borderline tumor, I know there will be a talk on borderline tumor today. I look forward to see my colleague presenting. But in borderline ovarian tumors, again, in the young patient, we should be trying to preserve fertility and preserve at least one of the ovaries and two. And finally, in endometrial cancer, in the young patient, where we know we have a type 1 endometrial cancer, and when you know that this is hormonally driven, there is plenty of data at the present time to kind of treat these patients hormonally, and they can be cured and get pregnant after that. And there have been case series after case series and case reports confirming that. Medical therapy. So I mentioned before that medical therapy was really confined to chemotherapy. In the 50s, 60s, 70s was the breakthrough with the platinum, and then 90s with the Taxol, and we stagnated. But then what was exciting and interesting, that all of a sudden we started to understand tumor and microenvironment of the tumor more and more. And the work that has been done on the benchmark started to kind of teach us a lot of things, how the tumors grow and how the tumors interact with their environment. So one of the most important concepts that kind of was introduced by a surgeon, in fact, who was working on different cancers in Harvard, is the role of angiogenesis in cancer. So what we've learned is that there is a yin-yang, essentially a balance between the cancer cell and the blood vessels. And there are a number of proteins that are secreted from the tumor itself, but also from the microenvironment of the tumor that helps that tumor grow. So vascular endothelial growth factor, fibroblast growth factor, platelet-derived growth factors, angiopoietin. All of these are proteins that are secreted in the tumor environment. And these proteins, what they do is they start stimulating the formation of new blood vessels, what's called neoangiogenesis, so that these tumors, as you see down on that cartoon down there, where these green cells, these are the cancer cells, all of a sudden start stimulating the formation of new blood vessels, and these new blood vessels feed into the tumor itself. And by starting to kind of reach to these tumors, all of a sudden what's happening now, the tumors have access to these blood vessels, and cancer cells kind of float into the blood and migrate into the blood. This has been at the basis of starting to understand, can we block that mechanism? Can we reverse this? So drugs that are what we call reverse angiogenesis or block angiogenesis became a significant part of what we are doing at the present time and how we treat cancer. So one of these drugs that we started looking at is a drug called bevacizumab, commercial name is Avastin. There have been a number of studies at the present time in the past 10 years that have shown that the addition of Avastin to the chemotherapy that patients get in the setting of primary ovarian cancer does improve disease-free survival. It did not improve overall survival, and this is why in the States it is not currently approved as a primary treatment for ovarian cancer. However, there are a lot of studies that can improve overall survival in recurrent ovarian cancer. So Avastin at the present time is really one of the mainstays of treatment that we use in treatment of recurrent ovarian cancer in the United States with impressive results, things that we have not seen before. And what is interesting in Avastin is because it impacts this blood vessel formation, a lot of the symptoms that patients get, such as ascites or pleural effusion, dry up. So even though these patients are not being cured of their cancer, but we are getting to get them to live longer with a better lifestyle. Another anti-angiogenic agent at the present time that has been investigated, and there are some very interesting studies, is cenerenib. It's another kind of medication which also inhibits angiogenesis in a different mode given in different route than bevacizumab or Avastin. And cediranib is also proving that it is really effective in ovarian cancer. Cervical cancer, the same concept applies. Tumor needs blood supply, blood vessel. So there was a very large study that was conducted and completed about 3-4 years ago and published already that have shown that in patients with advanced, metastatic, or recurrent cervical cancer, the addition of bevacizumab/Avastin to chemotherapy does improve overall survival. And this is the first time really that we have been able to prove in cervical cancer in patients with advanced disease that there is a drug that indeed changed the survival of these patients. Now, unfortunately, cervical cancer is prevalent in areas where getting access to Avastin is not easy. Avastin is an expensive drug. So while we had a success and discovery that is very, very important, the reality at the present time, the people who really need the Avastin the most cannot afford it because of where the disease is prevalent. With endometrial cancer, there are also studies showing that Avastin, anti-angiogenic agents, are important and will make an impact, and we sometimes use it in the setting of recurrent ovarian cancer. I want to take a little bit of time also as I'm talking about that angiogenesis now to talk about the concept of circulating tumor DNA and circulating tumor cells. So if we are to go back to how the cancer cells get access to the blood, in the past we thought that, well, really the tumor do not, except if you have a blood malignancy, such as a leukemia or sometimes lymphoma, that cancer cells rarely get into the blood. Well, what we are realizing that this happens much more frequently than we really know. And at the present time, there is more and more data that if you are to take the blood of individuals who have cancer, you are able to measure either circulating tumor cells or circulating tumor DNA, because we know the DNA of the tumor cells is different from the normal DNA. And by doing this, you are starting to prognosticate at the present time people who have circulating tumor DNA in their blood at certain levels or after treatment might be at high risk of recurrence, and therefore you can start stratifying these patients and decide how to treat them. The other thing that was interesting in the past decade, as we started understanding more and more, again, cell behavior, tumor behavior, we started understanding how the cells were evading treatment and how they were repairing their DNA. Both chemotherapy and radiation cause break in DNA. So people started to kind of spend more and more time understanding how does DNA repair itself. So on this cartoon, on the right-hand side, on your right-hand side of the cartoon, there are type of damage, repair pathway in green, and repair enzymes in red. And types of DNA breaks are either double-stranded DNA breaks or single-stranded DNA breaks. And the repair of double-stranded DNA breaks and single-stranded DNA breaks are totally different. In double-stranded DNA breaks, you need one of the main mechanisms of repair is what we call homologous recombinant repair, HR repair. And this is something that is dictated by genes such as the BRCA1 and BRCA2 genes. The single-stranded DNA repair is repaired by another set of enzymes such as PARP, polymerases, MSH2, and MLH1. So we know that the cell has its own kind of shop, garage of repairing its DNA when it gets broken, whether it's broken spontaneously or it's broken by treatment. And its ability to repair its DNA in such a fashion allows these cancer cells sometimes to recover from chemotherapy and to develop resistance to chemotherapy. So investigators started kind of focusing on this concept of DNA repair and see if we prevent the DNA repair, are we able at the present time, or can we get a better outcome from the treatment that we get? And this is where the whole concept of PARP inhibition got into play. So you remember that PARP is important to repair single-stranded DNA. So the concept is if you come here and inhibit PARP inhibition in cells that have a deficient HR recombinant, homologous recombinant HR repair mechanism for the DNA, then you might be able to kill that cancer cells. And this is here, that concept of DNA repair and how to fix it and how to address it is really the concept that has been used in the setting of ovarian cancer at the present time. And this is where the addition of PARP inhibitors, specifically in the setting of patients who have that recombination or repair broken down, such as patients who have BRCA1 or BRCA2 mutation, is being capitalized on. So currently, there are 3 drugs that have gained FDA approval in the United States based on the clinical trials that they've had. All of them are PARP inhibitors, work in a different fashion: olaparib, niraparib, and rucaparib. All of them targeting DNA repair, and all of them focus on improvement, the outcome of patients of ovarian cancer. Most of these are done either in a sequential setting after chemotherapy, so you give the patient chemotherapy, you break this DNA, the patient is in maintenance, you keep them on olaparib afterward, or niraparib, or sometimes in combination with chemotherapy. The other big discoveries at the present time, the immune checkpoint in a blockade. So the question has always been, if the cancer cells are foreign to our body, or are different from our normal cells, how come our immune system does not attack them? And this is where people started doing more and more discoveries, and the concept of immune modulation has been present there for a while, but now it's starting to get traction because I think we have some of the better answers. We know there are a couple of proteins that kind of click together, PD-1, PD-L1. You see these on that between the blue cell up there on the right cartoon and the white cell, which is a T cell, and that PD-1, PD-L1 kind of interaction essentially allow the cancer cells to hide itself from the immune system. It prevents the immune system, the T cell, of proliferating and kind of recognizing how to kind of attack the immune cells. So investigators have come up with molecules, with drugs, that will inhibit that interaction between PD-1 and PD-L1, either targeting PD-1 or targeting PD-L1. And by doing this at the present time, what you've done, you've kind of unleashed the immune system ability to attack the cancer cells. And there are places like lung cancer where there have been very, very interesting findings on that. And we are starting to see early studies at the present time in the setting of gynecologic cancers. What is interesting is all of these concepts link with each other. The concept of angiogenesis, DNA repair, immune check inhibition, all work together, because it is felt that if you have cells where we have broken DNA and are mutated, you should be able to get the immune system to recognize them better and to be attacked better. So it is very possible that we'll see combination of these drugs, and in fact we are starting to see now trials being done to have combination of these drugs. Tumor molecular genomics typing. Old days. Well, what we did, we took a tumor, we look at it under the slides, and this is where we thought we are going to be, and we are going to make a difference. At the present time, we are way beyond this, because now we are looking at typing every single tumor that we look at with a number of genes. So there have been now ovarian cancer, endometrial cancer, and cervical cancer all have had significant genomic typing, looking at all the variation that they have in the genes at the present time, and trying to stratify tumors not according to how they look, but what their molecular typing is. Why is this important? This is important because we knew that you will take 5 patients who have a type 2 endometrial cancer, treat all of them the same, the 5 of them having the same stage of the disease, and some of them are going to do well, and 1 or 2 of them are not going to do well. So really we're kind of throwing drugs on a heterogeneous population of patients and not understanding who is going to do well and who is not going to do well. The reality at the present time is we are going to start differentiating people based on the genetic making of their tumor and see what drugs work better than others in specific patients. I'm going to just touch on cervical neoplasia. I know that there is a symposium that Dr. Mahideen Saud will be giving on screening, but all of us know this story. At the present time, cervical cancer, I will venture to say, is an infectious disease. It is HPV related. We've known that. 30, 40 years of investigation has proven that cervical cancer, 99% of the time, is an infectious disease. It's HPV related. HPV gets integrated in the cervical cells, leads to kind of neoplastic changes and develop into cervical cancer. And accordingly, we treat it as an infectious disease. How do you treat infectious disease? You screen for them, you try to prevent them, you vaccinate for them. This is how we do it. We know that most viral therapy, we have more and more antiviral therapy, so we can treat HIV now and cure them. But with HPV, we have 2 other ways at the present time that are very advanced and should be able to help us really eradicate what we are looking at. One of them is testing. So this is an older slide talking about pap smear and HPV co-testing. I can tell you in the United States at the present time, all the testing that we do will include HPV, and now there is more and more data, and it will get presented a little bit later, about HPV testing by itself, even without pap smear. So this is not an if or but. This is not like, well, it might be possible. This is really standard. This is how it is used at the present time, and this is how we are going through. And the reason behind that is that the old days of getting these low squamous intraepithelial lesion, low-grade squamous intraepithelial lesion, and I don't know what to do with them and what to do. It's just solved. We have data to tell us that when you have high-risk HPV, you take a certain path, and when you have a low-risk HPV, you take another path, and you avoid treating the patients and over-treating them. The other exciting thing is vaccines. So you know about Cervarix, you know about Gardasil, and now we have nanovalent Gardasil. And there is a data that is very kind of convincing regarding this. So there is no question in my mind that we are going into an age where cervical cancer can be eradicated, and I kind of mentioned some of these opportunities in my conclusion slides. Just wanted to share this with you, although this is not cancer related, but this is really related to where medicine is going at the present time. So all of us is an NIH-funded 1 million participant trial that's going to go over the next 10 years. And essentially what it is taking, that it is built on the concept that we are made differently. Our genes are different. But there are many other things that impact our health. Our lifestyle, what we are exposed to, our environment. So if you see at that middle part there, where you have your gene, your DNA on the top, but what you eat, how you behave, what are the things that are exposed to, change what you end up with as far as diseases. Not only that, it will change how will you react to certain medications. So this $1 million, in fact, I just enrolled myself in that person study where they kind of take a baseline blood testing on you, do a baseline testing, and then they are tracking people, tracking their activities, tracking what they are eating over time, doing DNA typing, doing protein typing on them, and see how these things interrelate with disease in the future. The other issue, the concept is pharmacogenetics. This is there now. It does exist, and it is being more and more implemented. And the whole concept of it is that we process drugs differently. The way our body reacts to drugs, whether it's chemotherapy or PARP inhibitors or anti-angiogenesis, varies from one person to the other. And we know that sometimes how we give drugs can cause more side effects to us, and we know sometimes that it might not be as effective. So the ability to kind of know what drugs we react to better and we don't have side effects to is going to be a reality coming up soon. This is my last slide. I'm really excited about the future of healthcare. I'm really excited about the future of GYN oncology. But we have a lot of opportunity. As I said, with cervical cancer, we kind of have broken the code. We have found out what caused it, and we can prevent it, and hopefully we can eradicate it. The issue is not going to be possible without every one of us being aware, teaching, and adopting this. And hopefully in places where they do not have the resources, that we can implement population-based screening and detection as well as prevention with vaccine. With ovarian cancer, unfortunately, a lot of discoveries, case fatality rate continues to be high. We've not eradicated the disease, neither have we been able to cure it. So all of these drugs that I've told you have helped increase the survival, but that have not cured the disease. The only way we'll be able to cure it if we have an earlier detection possibility. With endometrial cancer, it is the majority of it, not all of it, but the majority of it is a disease of obesity. Obesity is an epidemic. You are a primary care provider. The women that come to you and come to us trust us. And I really think at the world level, we need to start combating that kind of epidemic of obesity. I see what kids are eating at the present time. They are sedentary, they are not doing anything, and we need to fight this because it has significant health implications, including cancer implication in women. Thank you very much, and I really appreciate